said I enjoyed listening to it.
All right, y'all ready? I have got this thing up and going, I think. Okay, we're going to talk about burns. Now, a lot of stuff that you've learned about burns, you've already learned as an EMT and advanced EMT. So some of this stuff will move through fairly quickly, but there is some material in here that you may have heard about, but I heard that you guys haven't really learned it yet. We're going to spend some time talking about the Parkland formula, or the consensus formula. If you read your chapter, then you read that part, so I'll bet 50-50 that some of you have heard of it or not. So we will work out some of those problems. We understand that there is a lot of Parkland formula on National Registry. So you're just going to have to learn it. But it's easy though, it's not hard. But that's probably the main thing we're going to be looking at. We're going to be looking at the different types of burns, electrical burns, chemical burns, what else? Thermal burns, radiation burns, and crush syndrome. I don't remember that being in here. And some different things like that. So ask any questions. Hopefully I'll have the answers. But we'll see where we go. The purpose of this presentation is that you better understand burn shock and how we're going to treat it. You see a burn, if you see a really, how many of you have seen a really nasty burn? Yeah, they can be really nasty. And so what was it you mostly were looking at? The burn. Ooh, that looks so nasty. Have you seen a really nasty 3rd-degree burn that like goes down to the bone? Seen some of those? Yeah, those are really bad. So it's easy for us to get tunnel vision and forget that just because they don't present with airway problems immediately, it doesn't mean they won't have airway problems. They don't present with shock immediately, that doesn't mean they won't present with shock. So we have to understand what we're dealing with so we can be prepared. We're going to look at our fluid therapy. As I said, we're going to look at the Parkland formula, aka the consensus formula. We don't excise dead tissue in the field. They'll be doing that in the ER. But a lot of people used to die from burns, and now they're able to save them. I'm not real sure I'd want to live with some of that. Where's the closest burn center around here?
UAB or Columbus.
Does Columbus have a burn center?
Atlanta. UAB.
Which one is in Atlanta? What's it called? Atlanta Medical Center?
We call it the burn unit.
No, this is the burn unit.
We still call it that.
What is the name of the one in Atlanta?
The burn unit.
Brady.
Brady? Brady has a burn unit?
Brady.
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 Hello?
Brady?
Brady.
Grace?
I was born in Emory. I should know these things. Okay, y'all ready?
Does Emory have one?
I don't think so. I just haven't been going there. What's the purpose of burns? Of skin? What does skin do for us? Now your book had 4 things. I had 5 things. What? It what? It's thermal regulation. Where were they? Thank you. I appreciate that. Shock absorbers. What else? Somebody said thermal regulation. Is that it? Fluid balance. Keeps the good stuff in, the bad stuff out. Think of anything else? It's a what? Protects. Temperature regulation, fluid balance, and sensory. You know, if you burn your fingertips off, then you're going to have a difficult time sensing. So that's an important function. Oh, yeah, that looks really bad. You ever known anybody that's had a serious burn? Not just you see the burn, but the after effects. They can be quite serious. Okay, with these patients, even after they burn and they've healed, that scar tissue does a lot of negative things. It doesn't allow them to sweat. If you can't sweat, what does that interfere with?
Thermoregulation.
Yeah, your temperature rate. You can't cool yourself very well if you can't sweat. They also have diminished sensory. Their sensory nerves have been burned off and they heal over. A lot of problems with that. Their vascular system is interrupted, it's not able to vasoconstrict and vasodilate appropriately. And if you've got a large portion of your skin, say 50 or 60% of your body surface that's burned with scar tissue like this, you can imagine the problems that that patient's going to have. And probably, what's the one that probably is the most detrimental to them?
Social.
Yeah, it's a devastatingly awful thing to look at. So yeah, they're very disturbed by that. So besides the other things, they're not able to tan their skin. They burn very easily because they don't have any melanin in their tissues anymore. Can't grow body hair, which might not be so bad. We already said loss of sensation. Let's look at the layers of skin. You guys already know this. Briefly, the epidermis. And the epidermis actually is made up of several very thin layers. What's on the very top layer? Dead skin cells, yes. Kind of like a protection to you on the outside. And then the very slim layers right under that, what are they doing? Yeah, they're making new cells. So all that's part of the epidermis. The dermal layer, that's going to be under the epidermis, and a lot of stuff goes on there, takes place there. What kind of things are taking place in that second large layer? Got your hair follicles. What takes place in that layer of your skin?
Hair follicles?
No, second layer. I don't want to know about your hair follicles. We've got the collagen fibers. We've got mucopolysaccharide gel. That's going to be like a mushy thing. It kind of gives our body that little bit of pliability. Kind of keeps it taut in there. All right, when you see a star here, if I remember to put a star here, that means we got a question next. So get your clickers.
We think.
Y'all ready?
Yep, been ready.
Well, I do have activity later on that we're going to do this morning that you get some points. Okay, the constant shedding of the outer layer of skin is known as?
Normal size.
Yeah, try that.
Oh, it is clicker. Mine's not working.
Look at Daniel.
Already clicked. Green. Mine's not working.
I got 20. I think I should have 20.
Mine's green and red. It's not working.
Well, let's see how we did. Anybody familiar with these terms?
I'm just familiar with the.
Some of them I made up. Okay.
Good big word.
Desquamation. 55%. That's good. That means you had to have read your book because that's not a term you would just
I read
learn.
it and memorized it.
The layers of the skin. Y'all make sure y'all read this chapter because we're just going over the top points. We're not going every single page, every single
So we're
paragraph.
just going over the epidermis.
Kind of like that, yeah. We make a little bit of the dermal layer in there. Okay, beneath the dermis, the subcutaneous layer. What else contains the subcutaneous layer?
Adipose tissue.
Mostly fats and adipose tissue in there. What's going to be below that?
Muscle.
Muscle. What's below that? Yeah. So for us, we mostly just looked at the top 3 layers, but they're also considered other layers all the way down to the bone.
What's below that?
Below that, what's below the bone? What's inside the bone?
Osteoblasts.
Yeah.
Yeah, that's point. You gotta put it around.
Okay, y'all had the eye lecture the other day, didn't you?
Yes.
Did that creep you out?
We didn't do
We
it.
didn't have an hour.
Yeah.
We didn't do that.
You haven't done it yet? I guess it's coming up. I don't like the eye thing. But you should know that the eyes are very sensitive to thermal heat as well as chemical burns. You've got a thin layer of fluid, little tears that lay over there. And if that stuff gets heated up, it can really damage the eye. So the eyes are very, very susceptible to burn injuries. The tissue around the eye also is much thinner. The eyelids are quite thin, some even more so than others. Pathophysiology, burns or soft tissue injuries created by destructive transfer. We know this. Radiation, thermal, electrical injury. All right, I got to start. Y'all ready? Which tissue is more sensitive to high pH? And pH would be important for what kind of burns? Probably chemical burns? Probably. Which tissue is more sensitive to high pH? If you don't know, you at least got to guess something. Ileocecal, I can't even say that word. I don't know what that is. Ileocecal, is that right? Did you just make that up?
No, ma'am, it's right there.
Okay, good. Wait!
What's the right answer?
The answer, I'm pretty sure the answer is ocular.
I'm gonna whip it up on my computer.
I went with mucosa.
That's That's okay. It's ocular. See, I forgot to put the right answer in there. I'll have to go back and look it up. Okay, burn shock. The problem we have with burns is two things occur. One, we have a lot of fluid loss because one of the primary functions of the skin is to keep the fluid in, right? Unless we need to sweat it out. So if all the skin or a large portion of the skin is burned off, there's nothing to keep that fluid from evaporating. Another problem that we have is we get fluid shifts within the body. And that causes problems partially through the leaky capillaries that we have, as that leaks out of the vascular system and it gets into the tissues and the extravascular space. So that is not good. So we with burns, we have a very large issue about fluid loss. Whether it's external fluid loss or it's loss within the body, it's out of the circulating blood volume. All right, y'all ready? Got no star up here. Okay, which could quickly result from extensive burn injuries? Y'all not getting on this one very fast. Clean red?
It might be about to blow up.
Yeah, who's blowing it up? Flip it off there.
It is ocular.
Oh, good for me, thank you. Come on, y'all, a few more of you. Or you wait until you look up the answers in the book before you pick one.
Let's do more of a absolute.
Come on, we should have two more in here.
Is the number
Going
in here?
in. Whoa! Whoa, these are all over the place. What a shock. At least the majority of you got it right. Who picked that answer?
I read the book and memorized it.
Hillary, why is that answer right?
I just remember the fact that you don't bleed a lot when you have burns.
I'm going to have something better than that. Who wants to make no stand at it? What?
What did Nancy say?
It's not B, C, or D, so it's A. That's why I did it.
Why is it A though?
Because
Not the
you
process
don't
of
increase
elimination.
your blood pressure. Because you're
No, look at A. Why is A right?
I'm telling you why I put A.
Well, why is A right? Not why the others are wrong.
That's
why
why A's
A-
right though, because the other
I
ones are
just
wrong.
told you why A is right. Use your brains.
Take it out. All right.
Loss of moisture. You're losing a lot of fluid externally, but you're also losing a lot of fluid out of the vascular system. If you take that fluid out of the vascular system, what's going to be left? Your formed products. You're going to have red blood cells, white blood cells. What else is in there? Platelets. What do platelets do? You know, as your blood starts to get thicker because the fluid's moved out, of course you're going to have an increase in clotting, right? That'll make me crazy. Okay. When you have a patient that has a burn, even if it's just like a 20 or 30% burn, it really affects the entire body. Those fluid shifts are a big part of it. So fluid resuscitation is a big deal for us, and we need to start it much more quickly than we usually do. You know, just because they're not showing signs immediately of that fluid loss, it's going to happen very rapidly. So we're going to have to be ahead of that curve and get it started. You what? I'm sorry?
Start an IV on somebody that's completely burnt.
Yeah, it's really challenging. Hopefully you can find some point in their body that you can start one. You know, it may be an EJ, it may be in the foot, you may find some unusual veins that you may be able to do that. And sometimes you might have to go right through, I would find the least affected area and try to find something there. But if you don't get some
Like
fluid,
somebody's falling in like a contained grease pit.
if they've got that all over them, they're going to die. And they're probably going to die before you can get them out. With thermal burns, they can get usually about 111 degrees is when the body starts to burn, the tissues start to burn. But you know, you can have burns from thousands of degrees. But it's going to depend on a lot of different things. How long you're exposed. Bo, I'm about to move you right up here. Did you get that recording? We're talking about Bo. It's cutting up in the back. There, it's been saved for posterity.
3 times now, but I'm going to go through the beam.
Yeah. Oh, Bo Nichols. We don't want to confuse her with anybody else. Now, say you touch a hot stove, what's going to happen? You touch a hot stove. You move your hand very quickly. say you are a diabetic and you've got some neuropathy and you put your hand on the stove, how quickly are they going to move that?
Smell like cooking.
Yeah, only after it starts to cook. So the amount of time that it's exposed to that heat, as well as how concentrated the heat is. You know, if you touch something and it's 115 degrees, it's nothing like if it's, 1,500 degrees, right? So the concentration, the amount of heat, how long it's on there, those are going to have an impact on how bad your burn is. Heat energy can be transmitted in a lot of different ways. I should have taken that picture out. It's just awful for me. They can get a flame burn, scald, contact burns. What else is on there? Steam burns. Which one of those is going to be worse, you think?
Steam.
Yeah, steam hurts really bad, doesn't it? But those also dissipate very quickly. So unless you're right over steam that continues, and there's a burst of steam, kind of like, you open the oven and you kind of get this wave, it dissipates fairly quickly. Let me see. Flash burns, I hate those too. All right, y'all ready? Did you see the star? Top. The burn zone farthest from the source is the zone of farthest from the source.
It is now.
Yes.
Just got added to the physics.
In the book, it's described different zones. I tell you,
I remember.
kind of like, cool zone, hot zones, warm zones. Okay, chop. Everybody's waiting on you, trying to make up your mind.
And then it's danger zone.
The zone farthest from the source.
When in doubt, go with C.
Let's see.
C's the answer.
Interesting. Answer is
Boom. Explain yourself, Jake.
Yeah. You
Highest
can't
fire
say.
and the highest and farthest away. That's the reason I went.
the highest, like A. Is that what you mean?
And it's
I
It
think
says it's the least effective, not the either. That's all it has in the book.
read your book,
It
guys.
says it recovers in 7 to 10 days. That's all it says.
no, there's something else in there.
Burns home, feathers away.
There's 3 zones, so.
Three zones. Anyway,
Right there.
you gotta
Coagulation
read your
and
book.
stasis.
It's right
That
here.
shows it's not
The
even.
coagulation is where there's no blood flow. This is when the burn, say you've got a second or third degree burn. The zone closest to the middle, the skin is basically melted down there. That's the zone of coagulation. There's no blood flow there. Zone of stasis, within the first 24 hours or so, 24, 48 hours, you get necrosis, tissue death. The zone of hyperemia, cells recover in 7 to 10 days. So as it moves away from that primary burn, these are the different zones and how they heal. And the statement of the book said salvage as much of the injured tissue as possible. That doesn't mean like you like gather it up, take it in with you, like it sounds like. But you want to try to preserve or save as much of the tissue as you possibly can. And the way we're going to do that, one of the primary ways, is going to be fluid resuscitation. Okay, y'all know these, right? Sunburn is considered what?
First degree.
We don't call it first degree anymore. Superficial.
Second degree.
Partial thickness.
Third degree.
Full thickness. Yeah, those don't look too good, do they? Okay, superficial burns, is like a sunburn. It only involves the epidermis. It can be quite painful, but usually doesn't give us any serious long-term damage. Usually will heal up pretty quickly. Partial thickness, how do we recognize a partial thickness typically?
Blisters.
You're going to see blisters, and of course we all want to pop those, right? Y'all want to, but you don't pop them. There's no popping of the blisters. And they may be, it says partial thickness, and that's going to be relative too. Some of those may be a little bit thicker than others. And the full thickness burn, what type of injury do you think that was? It looks like an electrical,
Looks like a blowout, so.
or he could have like burned it on a muffler or something if he was too dumb to wear shoes. And some of them do that. I've had a few motorcycle riders that have on flip-flops. Okay, with the full thickness, it's going to go all the way down through the subcutaneous fat. It may not go down to the muscles and the bone, but it's a possibility. This tissue is not going to regenerate. It's burned forever. The damage has been done. It's permanent. Burned off nervous tissue, vascular tissue. This is going to have some surgery to be fixed. We also call this eschar, and it may be black, white, waxy, all in there. Eschar is that word. Charred. Already told you that. Okay, steam burns. One thing about steam is as you inhale that, it's usually going to be maintained in the mouth and the upper, around the larynx area. Usually the steam doesn't reach to, it dissipates before it actually gets down to the lungs. The problem we're going to have with other gases, like in a fire situation, is going to be the chemicals that are actually in the gas as you breathe that in, which will damage the lower airway. Smoke inhalation. Where do most smoke inhalations occur?
In smoky environments.
Well, what kind? Does it happen like at the lake, in a forest fire? Yes, mostly home fires. And it's not just the heat, but more likely the chemicals.
Smoky possibility.
So you may see patients with thermal burns to the airway, primarily the upper airway. Probably one of the biggest insults is going to be the hypoxia that's created. You know, when you breathe in those superheated gases, there's much less oxygen remaining in that gas as you breathe it in. So they're going to be hypoxic. Tissue damage, of course, anywhere in the larynx. If you get a real hot shot of steam to the upper airway, what are you going to be looking at from here up? A lot of edema, a lot of swelling. So how would you recognize a patient that possibly had, inhaled some very hot gases? Maybe, but if it's just hot gases, then you may not see that. Yeah, you may have stridor. Their voice may sound scratchy or different because of that swelling. It's going to interfere with the vocal cords and their ability to vibrate. Well, I didn't tell you. Y'all ready?
Yeah, ready.
This is carbon monoxide. Has a blank times greater affinity for the hemoglobin molecule than oxygen does.
It's not the same, right?
Yeah, I try to move those around. So. If you had me for EMT, you should know this. We talked about it. Here was mine. Was it in the book? You read the book? Then you're in business. All right, let's see how we did. C is the answer. 250 times. So what you're saying here is the hemoglobin molecule is going to attract a lot more carbon monoxide than it will oxygen, so it's a big deal. Carbon monoxide develops because of incomplete combustion, and it's a byproduct of that. So the less efficient the fuel source is, the more carbon monoxide is going to be given off. And as I said, carbon monoxide is going to displace oxygen anytime that it can. So how are we going to treat that in the field? Massive oxygen, yeah. They used to tell us that you would take your patient to the hyperbaric chamber and that pressure would reverse this, but they found that in the short term, not so much. In the long term, it may be used for healing, but in the short term, it hasn't been as effective as they thought it was going to be. How are you going to recognize the signs of carbon monoxide poisoning? Y'all just kind of raise your hand if you know. How are you going to, what's going to make you suspect carbon monoxide poisoning?
More than one patient.
Yeah, if you've got multiple patients with similar complaints, of course they could all have the flu, right? Headache might be a giveaway. What else? Maybe nausea. It's kind of like flu symptoms. What is the description of the headache that people generally will give for carbon monoxide? Yeah, they say it's going to feel like a band tightening around their head. What if you had some people, say, in the den and they're complaining of nausea and a headache, and you've got unconscious people, back in the back bedrooms?
Probably remove
Yeah, don't go back there.
it.
Well, what are you thinking?
Something not safe.
Tired of the back.
Yeah, evidently the people at the back are closer to the source than the ones in the front. What else could it be if you've got little kids that are passed out and you've got adults that are just feeling sick? Kids are more susceptible because they're smaller, so the effects are going to be greater for them. When you're doing your assessment on a patient with possible carbon monoxide poisoning, remember, don't trust your pulse oximeter. What are you going to trust? You know, back in the
Mental
days before we
status.
had pulse ox, we had to use other things.
Mental status.
Which is not.
Yeah, mental status is going to be a biggie. What do skin signs look like? You know, but
Yeah.
mental status is going to be a biggie. Okay. With burns, any type of burn injuries, it may not, well, not any type, they're burned all over their skin, they'll be apparent. Sometimes with an airway injury, that injury may not be apparent. You know, that swelling doesn't happen immediately. Patients are dynamic, remember? So at this point, they might be breathing fine, their speech is fine. 30 minutes later, their airway could completely close. So you have to be constantly reassessing your patients. Scene size up, do not run into the burning building unless you're, like, have your pack on, you've got your mask on, got all your gear on. Don't go in there unless you're properly trained. Bad things can happen in there. Sorry? Make sure you stay someplace safe until fire department gets everything under control. If there's a patient in there, they're fully equipped to get that patient and bring them out to you. If you got somebody that's already burning, you know, they're on fire, stop, drop, and roll thing. That always helps. The more they run, the more they burn. Now, if you, as a patient, if they have, their clothes have smoldered and burned or melted into them, which, you know, cotton pretty well will burn off, but a lot of our clothes are plastic. You know, you've got a lot of other materials that are not natural, and those will kind of melt together, and it will basically become one with the skin. If you could easily cut some of that off, fine, but if it's melted into the skin, you have to leave well enough alone. So just leave it there. Okay, you're going to have to form a general impression, of course, just as you go down your trauma sheets. May be able to help you identify what's going on. You know, if it's a thermal burn, it's going to be pretty obvious, but if it's chemical, you know, chemicals can come through the skin, it can leave a terrible burn. You can inhale chemicals, and these may not be readily obvious. But one of the things that you will notice, and we've talked about mental status is going to be a big deal because hypoxia is a big deal relative to burns. Airway and breathing. Yeah, we mentioned hoarseness. If they're coughing, if they've got singed nasal hairs, if they're coughing up sputum, that sort of thing. Facial burns, carbonated sputum. And if they've been in an enclosed place that was burning, then it's more likely that they've got an inhalation injury. You know, they tell us that we should try to intubate a patient as soon as possible if you suspect that they've had an airway injury. Of course, a lot of those patients are going to be conscious for a while, so it may be very challenging for you. They recommend that we really not put a nasal tube down if they've got a serious airway injury. I'm not sure when they tell us that. But recognize that this might be the time where you might want to get a helicopter or somebody else in that can paralyze your patient and get that done. Most of the time, that airway swelling will be delayed till later. It's not going to be immediate, but if the worse the burn is, the more likely it's going to be a little bit sooner. So you may have to be prepared to attempt intubation, and you want to use a normal size tube or as big a tube as you can pass through there. If the airway's already started to swell and you're putting, you know, a 9.5 in there, you're going to tear that airway up. So you'll have to choose the one that's most appropriate. Another thing you want to do, and we all have the ability to provide humidified oxygen on the ambulances. If you haven't done that, you need to make sure you see the equipment and know how to hook it up. If you've got somebody with an airway burn, you want humidified oxygen. Who else might you want to provide humidified oxygen for? Old people? Just because you're old, let me give you some humidified oxygen.
We've been on oxygen for a long time.
Do what? Yeah, long-term oxygen users, yeah, they're like that. But as far as illnesses, pediatric patients, you know, bronchiolitis, croup in particular. Yeah, if you have a long transport and you've got a patient on 15 liters, yeah, humidified oxygen is not going to hurt anybody. It's only going to help most people. Circulation. This is the biggie that we're going to be focusing on today. It's going to be providing fluid resuscitation for patients. And during that first 24-hour period, the fluid is so much more important because that's when they're going to have their greatest fluid shift and fluid loss. It's important that you get them to the ER as quickly as possible. Don't waste a lot of time on scene with the burn victim as you're trying to get IV access. What is another way we can get some access for fluids? Yeah, you may attempt to IO here. It's quick. Once you got it set, it doesn't hurt too much. Do what? Okay, typically, when do fluid shifts occur after a burn? I didn't tell you this specifically. Did you already pick C?
I did. I bet it's either right answer or no.
Come on, y'all. That works for me. So now everybody's picking C? I should take everybody's names. All right, I know who got this right.
Oh,
That's the right answer. That's one.
you like C.
Okay. All right. Now, in your textbook, it breaks out 3 different scales for doing your rule of nines. The reality, if you go to registry, you're not going to have to break it down. You're just going to break it down into the 2, not into the 3. But they're all self-explanatory. Even as we move through to another form of rule of nines, it's pretty well self-explanatory. For the adult, okay, how much is the head? Is 9. If I just burn my face, how much is it?
4.5.
Yeah. Yeah, you gotta use your brains here. If, what is the whole torso here? 18. If I just burn like from here up, how much is it? Maybe 9, I might even go less than that. Yeah, use your brain here. How much is my whole arm? 9. If I just burn the front part right here? Just right here. Not here, just here.
Whatever.
Yeah, I'd probably go 2, 2.5, something like that. So use your brains here. What's going to be the main difference between an adult and a pediatric patient? Yeah, so what's the head going to be worth for a child? Yeah, the younger they are, it's going to be, it's the big thing. Yeah, it's 18. It's the big thing. So where do they take the other points away from? The legs and the arms, yeah. Okay, you know the palm method? I may have to use the palm method on some of you.
Was that a threat?
Did you record it?
No, but you did.
No, I just talked about it. Anyway, is it going to be all of your fingers too, or just the palm here? Yeah, it's just going to be the palm. Is it my palm?
Patience.
Patient's palm, that's right. All right, in your textbook, it mentions the Lunn and Broader chart. And you need to be familiar with this because it is in the national standards. So you could see this particular chart mentioned in National Registry. So be familiar with it. All it does, it's the same as the other one, but it breaks it down a little bit more thoroughly. Like the back, you know, from the waist up, it's going to be 13. But if you add all this up, it still comes up to 18, doesn't it? Yeah, pretty much. The arms, they're still going to eventually come up to the same amount, but it just breaks it down better for you. So if you have, so you won't have to use the Palmer method. So just kind of know what it is, but you can figure it out. It's pretty easy. Okay, transport decisions. Now, pretty much anybody with any reasonably bad burn, you're going to transport. However, Bo, probably the biggest decision you may make regarding a burn is going to be, should you go to just the trauma center, local hospital, or should you go to a burn unit? And I know over the course of my career, I've had several times where people have had apparently not bad burns, but they should have been in the burn center. For instance, if you get a burn on your hands, that might only represent a couple of %. But if they don't treat these properly, that person's going to end up with a webbed hand. So even somebody with just an isolated hand burn probably needs to go to a burn center to prevent them from having scarring. That
Like in Alabama, you only have a pretty one down center.
and take them to Georgia.
You call TCC, then they would take.
Yeah.
You're not gonna be like in Montgomery and
you can say that, but if it's you with that burn, would you want to get there?
I mean, I'd rather go to the hospital than transport me there.
That's a possibility. I mean, talk to them if they'll do that. But educate your patient. I've had patients before, you know, you just take them to the local hospital and they should have gone to a burn center. So even if you take them to the first stage for evaluation, tell them, Bo, you're going to have to pick your stuff up, come up here or out the door. You leaving? Or you come up here? Yeah, come up here where we can be close. Okay, now where were we? Yeah, so any injuries to the hands, the face, the genitalia, the bottom of the feet, between the fingers and toes, those are areas you're going to have terrible scarring, and you're going to need to be seen in a burn center. And of course, anybody that has a lot of other, we call it comorbidities, where they've got a lot of other illnesses going on, and then you tack a moderate burn on top of that, and they run the risk of a bad outcome from that. So anybody with pre-existing diseases, you're going to triage them up. They're going to be a level worse than a patient that doesn't have those things. Secondary assessment, make sure you look for the mechanism of injury, how they got burned. Thermal burn is easy. It's the other burns that are more challenging for you. Make sure you check the eyes too, because it may not be readily apparent that they have got a burn or chemical involvement there, so make sure you check the eyes. Look for burns that go all the way around the body at some point. What's the problem with the burn, say, to the lower leg that goes all the way around the calf and it's the swelling can cause what?
Cut off like circulation.
Yeah, what do we call that?
Depression.
Another word starts with a C.
That's correct.
What'd you say?
Compartment.
Compartment syndrome. I didn't hear you say that.
I read my book.
Compartment. Well, that's always good. Compartment syndrome occurs when, you know, Brandy mentioned how poorly y'all behaved last week, and I said, no, not those students. Just why? I'm sorry. Yeah, you guys asked to code 2 long days. That was not our choice. You guys
Well, it's only an
asked that.
hour longer than it would have been, so.
Yeah, you think? I don't think so. Only an hour longer. 3 days versus 2 days. Anyway, y'all asked for this. Do you think I teach for 5 hours tonight, and I don't quit talking for 5 solid hours, so my choice wouldn't be to be here, but I really care about how you guys do. And if you're going to chat the whole time away, you're wasting your money, you're wasting my time. So if you feel like you don't want to be here, just take it to the house. You can read it in the book. And I'd rather you do that than disrupt it for everybody else. There are a few people in here that would like to learn. I'm not sure who they are, but I'm sure there are a few. Me, for instance, I'd like to learn some. So if it's all right, we'll move on. If not, now's your chance to hit the door, and I won't think a thing about it. You just hit the door. Okay, what's the problem with compartment syndrome?
There's a lot of problems.
What are they? It damages your blood flow. The blood doesn't flow down and back. What are the other problems with it? What's the one thing your patient's going to report if they've got compartment syndrome? Not just pain. What?
Also feel it.
What's the number one thing that they're going to report more so than anything else? I said it's not just pain.
Is it not? Is it pain?
It's not just pain, it's severe pain. I mean, pain way, way out of proportion. Resume. We're halfway through, so you're not going to be here. You know, we've got probably another 45 minutes, and we've got our little thing that we're going to do here in a minute. So, secondary assessment. These are things you've been learning about the whole time. Your secondary assessment, what are you checking in your secondary assessment? Everything you didn't check in the primary assessment, right? Pretty much. Look at the circumstances and the mechanism of injury in case you're not sure what's happened. Look at the eyes. Check, we already said, did we do this screen already? Check for circumferential burns. Always check your distal pulses too, because if there's some swelling taking place internally, if you've got some compartment syndrome going on there, you're going to recognize that. If the patient's not complaining of pain, which probably will be, checking a pulse is going to be important. You know that for critical patients or unstable patients, you're going to check their vital signs or initial survey at least every 5 minutes. For everybody else, at least every 15 minutes. Definitive burn care, the only one that we're really concerned about is going to be like the first hour of the first 72 hours. But read through this so that you understand the process that a burn patient goes through. You don't go to a burn center, do you? Oh, but we had to go to a burn center and see all that kind of stuff. Have you ever seen them have to debride a burn after the fact? That's extremely painful. I just don't think they have enough hard drugs to give you for that. They have to put me out completely. But anyway, read through that. Our main concern always is going to be ABCs, and part of that fluid resuscitation is going to come under C for circulation. But recognize that they could have a lot of edema and a lot of swelling, so these patients may progress from stable to unstable much more quickly than just your average patient does. So they're at greater risk. You have to watch out for cardiac arrest, respiratory arrest, well, primarily. What are the patients that we have more likely to see a cardiac arrest at the time of the burn? Electrical burn, like if you get a lightning strike, something like that, yeah. Or putting your finger in a socket, I guess. Patients that initially are responsive, but they've had an inhalation injury, got to watch those guys for swelling. You know, in this class we've talked, did we actually do the crikes? We're going to do that in the fall. Yeah, that may be an option for you down the road if it's necessary. Patients with deteriorating airway are those that you may have to consider intubation on. If possible, if you feel comfortable, you can, if you're close enough to the ER, at least once you get to the hospital, they've got all the tools to paralyze them and get that tube in there. You hate to do that on a conscious patient, and you know if they got a gag reflex, you can't do it. You hate to wait sometimes. If your patient already has a history of respiratory problems, say they're asthmatics or other respiratory diseases, then an inhalation injury, chemical or thermal, can be much more detrimental to them. How will you manage your initial management of a patient with a possible airway injury? I already told you one of them. Humidified oxygen, of course. You may consider one of the nebulizer drugs. All right. If they're just a normal old patient, supplemental oxygen, always consider pain medications. Burns are extremely painful. And in the olden days, we didn't even give much pain medication. But these days, they want you to be kind of aggressive with that. So they're going to be screaming for it anyway, so find a way to get to them. Okay, fluid resuscitation. This is the biggie that we're going to be talking about. Anybody that's got a burn of greater than 20% body surface area, they're going to need to have fluid resuscitation. They find that if that fluid resuscitation is delayed more than a couple hours, they have a much less positive outcome from it. So you need to get those fluids on board as soon as possible. Okay. Our goal is going to be to approximate the amount of fluid that we're going to need to deliver to a patient using the consensus formula. I have got a little thing here. During the first 24 hours, y'all have had this formula already, haven't you? Have you worked through it? Some problems with it?
Yes.
Okay, so you should be okay with this. Good. All right, the first 24 hours, the formula tells you what the patient needs in the first 24 hours. For us, we're interested in what they need for the first 1 hour. So the formula is 4 milliliters times the patient's body weight in kilos, and then the percentage of body surface burned. That's going to be your formula. So let's say our patient weighs, if he weighs 100 kilos, how many pounds does he weigh? 220. Say he's got 25, do I have one more slide on here? Let me finish this first. So this is for the first 24 hours, but the first half of the fluid total has to be given in the first 8 hours. And so we're going to have to divide that out as to what they're going to give for 1 hour. So for instance, we have our guy that weighs 100 kilos. He's got 25% burn. So you multiply 4 times 100 and you get 400 milliliters. Now you multiply this by 25, not 25%, but by 25, and you're going to get 10,000 milliliters. All right, what are we going to do with this now? 10,000. We're not going to give 10,000 milliliters in 1 hour, are we? Are we going to give half of that? Okay, so what are we going to do with this 10,000? We're going to divide it by 2 to get what? Half of it. And then from there, we're going to divide it by what? By 8. And then that's going to give us what we're going to give in the first hour. So that's what we're looking at. So 225 milliliters for this patient is what we're going to give in the first hour. So probably our normal transport time, say, is 30 minutes. We're going to give half of that over the course of that first hour. So they're losing a lot of body fluids at this point. The other half is going to be given over the rest of that time. Do what? Oh, here's a question for you. The purpose of the Parkland formula was to, or is to, this was in your book. So less than half of you read the book. That's what I thought. To limit fluid overload. You know, when we look at those numbers here, 625 milliliters for the first hour, how much do we usually give a trauma patient? Yeah, it seems like a lot more than that, doesn't it? You know, you'll hang a 1,000-liter bag like that and open it wide open. So 625 for the first hour. So if we've got them for 30 minutes, how much are we giving them? 400 cc's. So they don't want you to overhydrate a patient that can't handle it at this point. I mean, less than that. Okay, pain management. With your burn patients, you're usually going to have to be given their pain medication at the high end of the range rather than the low end of the range. And make sure you're familiar with your meds. Like morphine, for example, you don't have to wait 5 hours to give them another, give them additional morphine. What's the range for morphine? 2 to 10? Anybody else? Most places I think it's 2 to 20. Our protocols, I think, say 2 to 10. Then you're going to have to call. But there may be times where with a burn patient, you're going to be given up to 20 milligrams. But you want to call before you put somebody in respiratory arrest.
We don't carry one.
Yeah, we won't carry 10 on the truck.
That's all right. I got a phone. I can call for backup. I mean, if you use all your lidocaine or something else, you can call for more, can't you? If you got 2 patients, you might need more morphine than that. So, yeah, you've probably got somebody, a supervisor, that can bring you more drugs if you need it, don't you?
If you got more than 2, if you got 2 patients, you're gonna have 2 ambulances, and they're gonna use 10 apiece.
Not necessarily. You're the only one in the county that.
Well, then you're not gonna get backup to bring you morphine.
I'm not stopping them out to the hospital.
Well, you probably have a supervisor, don't you, that does a transport? No?
You don't have
Okay,
anybody.
normal places do. Alright. IV is going to be the best way to give your pain meds. So try your best to get an IV. If you can't, you may consider drilling them up. Subcutaneous, intermuscular, those are not going to be effective for the same reason. You've got a patient that's in severe shock here, and if you're going to give them other routes, they're not going to be absorbed very easily. So IV is going to be the best route. Narcotics are the drug of choice. I think is everybody carrying morphine these days? Anybody that doesn't even have morphine? There are some services that don't, surprisingly. What other narcotics do you carry? Fentanyl, okay, that's a possibility for you. With pain, with your burn patient, you want to use the same scale you always do, scale of 1 to 10, and ask them that frequently. Give them that morphine, however you're starting with, 2 or 4 milligrams. Give them that, give them a couple of minutes. What's your pain like now? It's still 10 out of 10, then we'll get some more morphine. At which point would you titrate that back.
Decrease the respiratory rates down there.
Yeah, as the respiratory rate starts to decrease, or you're seeing respiratory involvement, then you've given all you can. You don't want to have to get involved with having to bag these poor patients. Okay, here is a question for you. I already told you this one. Yay! They got one right, Steve. They were listening. Okay. Burn shock usually sets in within the first 6 to 8 hours. Hopefully that's going to be happening somewhere else. But hopefully you've started your fluid boluses early in the process. It's important that it's not delayed. That 2-hour window is very important. If your burn patient is showing signs of shock in the field, you know, if you're able to get a blood pressure and it shows that they're real shocky, look for something else. They may have some other kind of injury, another traumatic injury that causes that. Or it's possible that, you know, they're taking medications that lower the blood pressure and now you've added this in. Might be a possibility. But typically, the burn is not going to result in real shocky symptoms early in the process. Okay, when you're assessing the burns, all these things, we talked about most of these that you're going to look for, is determining whether it's a first, second, or third degree burn. Check to see if there are any foreign bodies or debris actually in the burn. Now, with a smaller burn, or say even just a second degree burn or first degree burn, you know, we can cool those burns. But as they start covering more of the body surface area, you want to be less inclined to actually put a lot of fluid on there. But cooling, it's just like cooking a steak from a thermal burn. You cook a steak, remember you pull it off and it continues to cook for, you know, 10 or 15 minutes. Same thing, if you've got a thermal burn on a patient, if you don't cool that off, it's going to continue to burn. But you have to balance that. If they've got, say, a 60% burn across their body, you can't dip them in, you know, a cold water bath. So you have to be very judicious about that. Superficial burns, cool water, partial thickness. You can cool the burn. You can put a wet dressing on there. You can put a wet dressing on there, but don't leave it on there for any length of time. Go ahead and elevate the extremities. Get your IV in place. Remember too, if they've got any rings or jewelry or anything, you want to take that off because as that tissue swells, it may serve to act more like a tourniquet. And then of course your pain medications. Full thickness, you're going to get your pain medication on board probably a lot more quickly because what's that patient going to be doing? Between the partial thickness and full thickness, they're screaming bloody murder. Has anybody transported a really bad burn patient yet? They are screaming bloody murder. They're in so much pain. Now the full thickness, you know, probably right there at the full thickness, it's not real painful, but where is it painful? Yep, the peripheral edges. Yeah, those are going to be extremely painful. With a full thickness burn, we don't want to wet those. You want to put a dry, sterile dressing on there. I won't take anything. And you go ahead and get your fluids on board. Now, if you've got an inhalation burn, I mentioned doing some aerosolize, cool mist, that sort of thing. Humidified oxygen. I see that word mister and I think of like Mr. So-and-so. The mister's not there. Ice packs are okay if it's just a simple like a first degree burn. You need to do that. You may have to use aggressive airway management. How long should you apply wet dressings for moderate burns? It's whatever your textbook said. You read that. Make a stab at it, guys. Did you vote both? Okay. Didn't know if you fell asleep on the switch. Up to an hour. Okay, chemical burns. As long as that chemical is on the skin, it's going to continue to burn. How do we get chemicals off the body? Okay, if it's powder, you're gonna brush it off. Everything else you're gonna irrigate, right? How long are you gonna irrigate? Just until, you're just gonna keep irrigating as long as possible. Oh, yep, said that. So the amount of damage is going to depend on what the chemical is, you know, how it reacts, the concentration, the chemical state of the temperature. That oftentimes has an impact on it too. Is it liquid or is it gas? Can you think of some gas that we use frequently that would be much more dangerous in a different state? Oxygen. What would be the other state? We use it, what form do we use it in? It's a gas, but those big tankers carry it in a liquefied form. And you get some of that liquefied oxygen on you, it can be dangerous. But a lot of the gases that are used, when they're carried, they're in a liquid state, and they're much more potent. Length of exposure, depth of penetration. Now, alkalines burn much more deeply than your acids do. So depending on what you have, you may not be able to see how deeply that's burned either, but you got to know what the chemical was, hopefully. Acid burns are much more easy to neutralize. Their destruction is going to be closer to the surface. They'll cause coagulation injuries a little bit closer up. Whereas the alkali burns, they're difficult to neutralize, but they go much deeper than that. They go much deeper than the skin. They break down the proteins, the other collagens in the skin, and almost make it like a mess in there. It's a burn. That is. Make sure you decontaminate your patient. When you are flushing the skin, you know, like in this building, we've got a chemical shower where you can like wash that. Any industrial site is going to have a way for you to wash your patients off and decontaminate them. Copious amount of water. Make sure you take the clothes off because they're going to continue to burn the patient. If they keep those clothes on, every time they move, they're going to be spreading that to other parts of the body. So clothes have to come off. Make sure you wash between the folds. Excuse me. Once you've washed them, wash them again. Dry lime, y'all remember that from the EMT book? Brush as much of it off as you possibly can. Then you flush it with copious amounts of water. Sodium metals. I'm not sure what those are. Does anybody know what sodium metals are? Well, if you're at an industrial site or commercial site, the people there should know, be familiar with their chemicals, and they can tell you it's a sodium metal. You'll cover that with oil. Does anybody carry any oil? I don't. Okay, which of these would be an anecdote for pepper spray in the eyes? Some of you guys probably know this anyway. Some crazy answers. Anecdote for pepper spray in the eyes. Some of you guys are going to need to know this. So.
I have a question.
Okay.
You're going to treat the symptom or just the effects of the pepper spray or just the pepper spray itself?
This would be the burning. It's killing your eyes. How are you going to keep that from... I mean, isn't that what pepper spray does? It hurts so bad it stops that behavior?
Like the symptoms it causes or not pain itself, but I mean like the actual pepper spray to get rid of it.
Yeah, it's the symptoms that the pepper causes. I don't think the pepper spray itself damages you, but it's the pain that's inflicted makes you stop what you're doing. Okay, a couple more if you haven't voted yet. Let's see. The book said baby shampoo is one of these. Yes. You've used that, it works?
Well, it also says, like, Maalox.
Yeah, so I changed that. Put back.
Maalox.
Is that the same thing?
I would
Okay.
think. Well, it
So,
says baby shampoo.
Benadryl and atropine are definitely wrong.
We use the milk, water.
Yeah, the usual stuff. They all work about the same. Hydrofluoric acid. You may be in a circumstance where you will give some calcium chloride to a patient with a hydrofluoric acid burn. It's a possibility. Gasoline, diesel fuel, what?
Where do you get calcium chloride jelly?
would be for a topical. Maybe we can make it out of our calcium chloride. How could you do that? Works for me. If you got gasoline or diesel fuel, just wash that with soap and water. Hot tar, hot, how do we manage hot, cold, cold? Yeah. All right, more stuff. This solubility properties of gas gets quite complex, and I don't know about you guys, I'll never remember all of these substances. But this is a nice little chart, and if you haven't read this in the book, you need to read this because each one of these gases reacts very differently in the body as far as the amount of damage that it does. Make sure you read that, okay? Y'all gonna read it? Good. Hydrofluoric acid. Hydrofluoric acid is going to be a little bit different. If you don't manage this aggressively, this can be very quickly fatal. It binds with calcium ions. It can be enters the body through inhalation or skin contact. Primarily it's through refrigerants, but other things like if you do hobbies and you cut glass and things of that sort or make metal stuff, then you may use hydrofluoric acid. Assessment, hopefully somebody there knows what they've been using because the injuries may look very much the same. Assessments, upper airway, always, who let the bug in? You can recognize a patient if they've got lower airway involvement, if they have, we're going to have to shut the window as soon as he gets out, I guess. How would you recognize a patient with a possible chemical injury to the lung? Anybody? Yeah, difficulty breathing. These are not hard. You may hear some wheezing, you think? How do you manage a patient with an inhalation injury and they're wheezing? Yeah, I'd try one of beta agonists for sure. Okay. You want to make sure you check your pulse ox, monitor for airway compromise, consider beta agonists. Got one more in here. Which of these may be useful for chemical inhalation injuries? Kind of stumped you. Let's see. Come on, y'all. Everybody's waiting on you. Some people are falling asleep waiting on you. Okay, if your buddy sitting by you is asleep, wake them up so they can push their button. Oh, good job. I thought I stumped you here. Yeah, racemic epinephrine is something that's commonly used as a beta agonist for respiratory issues. Of course, all those others are kind of made up things. So.
Is that in the book?
No. I'm educating you here. Sometimes you'll get stuff that's not in the book. Chemicals known to cause burn to the eyes. Let me see, I could have figured out all these. Acids, alkalis, dry chemicals, and phenols. Ooh, that's a nasty eye burn. Management, you're going to flush their eye with copious amounts of water. Now make sure when you're flushing the eyes that you're not running it from one eye into the other. If you have a hose on scene, those can work quite well. What else works really well? Yeah, you could use IVs. Yeah, put a nasal cannula in there. You can flood both eyes that way. I guess that would be a possibility. Yeah, when a patient's got a bad eye, they don't want you to hold it open. It's very painful. Y'all familiar with any other piece of equipment you might use? If they've got contact lenses, excuse me guys, if they've got contact lenses, you probably want to get those out as soon as you can because they're going to hold that chemical underneath them and continue to burn. Once you've flushed the eyes for at least 20 minutes, you want to cover the eyes with a light pad dressing or something. You don't want them to continue to move them all around. Yeah, I'd probably do both eyes. But you just got to remember that they can't see once you cover both eyes. That's very stressful for them. This is a Morgan lens. And they're very useful for this type of injury. It's like a contact lens on the end of a tube, and then you hook that tube up to saline or whatever you're flushing with, and it irrigates the eye. So it fits on there. It's a little bit thicker than a contact lens. Morgan.
Where do you get that thing? I've never even seen one of those.
Well, how old are you?
We haven't been young.
You just haven't been around too much.
But everyone I've ever used, patients were not.
Well, they don't like anything. It's never comfortable to have your eye irrigated. Never. But take my advice. I worked with a guy one time, and we had about a 5-year-old boy that had done something to his eye, and he irrigated the eye with one of those 50cc syringes, you know, that we carry on the truck. He filled it up, came at that kid like this. Hold your eye open, I'm going to squirt it. So don't use that. It scares him. Okay, electrical burns. I like electrical burns. I don't like electricity. But one thing about electrical burns, it's almost like an entrance and an exit wound to like a gunshot. So you'll have probably a smaller entrance wound, and there's usually going to be some type of an exit wound. But all sorts of things can occur in between there, because if you've got a bolt of lightning, say, or a high voltage wire, as it enters the skin, it's not doing a lot of damage there, but it fries everything along the pathway. So you may have a lot of damage as it goes through. And of course, the exit wound, what's it going to look like?
It's gonna blow out.
Yeah, it kind of blows out. I've seen patients where it's really blown off the end of their foot, and it's kind of like, whoa, what happened to your foot? Not like that. Said that. Okay, there are a lot of things that will alter the amount of damage that occurs. One is going to be the resistance of the body tissues. Electrical energy likes to move along electrical pathways. And what would those be in our body?
The most resistant.
The nervous system, certainly, and the vascular system, because electricity likes to move through water. It moves very easily through there. So those systems primarily or particularly will flow easily electrical currents. How intense the current is, how long the patient is exposed to the current, all those are going to have an impact on what the burn is like. And there are a few different ways that you can actually be burned. You can have, that actual electrical injury where you stick your hand in something. An arc type injury, what's that?
Where you like, it's like where you basically hold on to it and it burns outside of you.
That sounds terrible. How about if you walk by one of those really high voltage wires, you know how your hair starts standing up and you create all that that static electricity? If you get too close to one of those, that's why they fence them around, you can actually draw an arc of electricity from there. And of course a flame burn. So that. Two common causes of injuries from electrical injuries are asphyxia and cardiac arrest. And I think we've probably talked about this at another level. If you get a patient that is unconscious after being struck by lightning, what's most likely going to be the problem here? It's what? Most of the time it's going to be respiratory arrest that turns into cardiac arrest because it's a respiratory arrest that's unrecognized. Could you get a cardiac dysrhythmia that killed you? Yeah, you sure could, depending on how intense the electrical stimulus is. But yeah, always check first for asphyxia. You may be bagging that patient until the respiratory center is, comes back online. It knocks it offline, and then they go into cardiac arrest. It could be, happening at the same time. But these patients have the potential to have a decent outcome if you get on it immediately. Y'all ever know anybody struck by lightning? Nobody? Dang, where have I been then? Lightning is kind of interesting, and I have some really good lightning articles in my office. If you have any interest in lightning and you want to read about those, it's not like.
There's a dude on YouTube who's got struck twice.
Really?
In a parking lot. He hits it one time, gets up, and it hits him again, like 20 yards down the road.
Yeah, you don't have to be all that close to lightning. It can be blue sky and be struck by lightning. So it's extremely interesting. So if you're interested, like I said, I've got some good articles. Just come and you can check them out. Let's see. With the lightning injuries, electrical injuries, because of the tetany that may be caused by that electrical stimulus, they may break bones in their body. Their muscles just tighten down so quickly it can snap bones. So make sure you look for those as possible injuries associated with an electrical injury. make sure that whatever has burned your patient has gone away. If they're, still holding on to the source and they got the whole shaking thing going on, what do you do about that? Yeah. Nay, stay away. Yeah. You want to make sure the fire department or the electrical company, whoever, is there to turn that off. Don't try to beat them off with a stick or anything like that. You're just going to have to wait and say, I hate it for you. Sorry? If they're pulseless, of course, you're going to start CPR. You're going to do all your regular stuff. If they're conscious, you want to do a good assessment. People can have serious injuries from lightning, even though they're not struck. They're just close to it. You get this splash over thing going. Treatment is going to be always ABCs, manage for shock, transport early. Now, I already got a question here. Kidney injury from muscle breakdown caused by an electrical injury. Okay, I'll give you an easy one. Come on, guys.
Maybe.
Come on. Who's complaining about all the definitions on the test? I wonder if this one's on there. Come on, who's asleep? Okay, see? Not so hard. Mostly because I made up some of those other words. Rhabdomyolysis. That's due to the breakdown of muscle tissue. The chemicals released will tear up the kidneys. It can kill you. This is the result of a lightning strike. All that feathering, it's just kind of weird, isn't it? Yeah. It kind of runs along the nervous system. Don't those look like little nerves, don't they? Yeah. Pretty cool. Anyway, your textbook spends a lot of time about telling you how not to get struck, like stay away from open fields, don't be the tallest thing around. It doesn't spend a whole lot of time talking to you about how to treat them. But if there's electricity in the air, I'm going to be the lowest thing, so that means I'm going to be down, you may be up. You don't have to have a direct hit. People that have a direct hit have a much poorer outcome than somebody that just has a splash over or somebody that's near. I worked with a lady that was on some metal steps going to the outside of the building when about 50 feet away it struck the ground. It came through a tree and then struck the ground. And she suffered from different side effects from that for over a year. Best treatment is prevention. Take shelter in a substantial structure. Those electrical things can come through your telephone. So an electrical storm or storms, you don't want to be on your phone either. And that means your cell phone too.
What about water? Have you ever heard of somebody getting struck, like in the shower?
It did not affect us.
They said, what did it? Was it freezing or not?
Yeah.
Come through your house.
Let that dummy up
Come through your pipe
Did it?
of your toilet.
in the whole 9 months.
Yeah, I wouldn't get in the shower during an electrical storm because I don't want to be wet when it comes. But anyway, lightning injuries can look like blast injuries. You kind of know what those look like, right? Here again, it's going to be respiratory support. With your patients, you want to make sure the scene is safe. If it's in the middle of an electrical storm, I'm sending the firemen out there. They're going to have to bring them to me. But make sure that you're safe. I'm just teasing you.
You married a
I know it. He'll have to go out and get them. They're better equipped for that. Their skin's tougher. Yeah, they can take a lightning strike better than I can. But get to a safe place to treat your patient. You may, like in a golf course, those people play in groups of 4 or 8 or something. If you get a nearby lightning strike, it may affect all of those. They may all go down. So you may have a number of victims here. Of course, be ready to start CPR. In the case of a lightning strike, you've got quite a few people that are affected. How effective is CPR going to be on somebody in cardiac arrest? I mean, we're talking about triage stuff here, right? What? You got black tag, the lightning injury guy?
Cardiac arrest.
A lightning strike in a group like this, that's probably the only time that I can think of where you may actually treat the guy in cardiac arrest because you have a good outcome with those people. you can easily have a good outcome. If you got a patient that just goes down in cardiac arrest, or particularly a real trauma, gunshot wound to the chest, your outcome is not going to be very good. But with these guys, you may have a good outcome from that. Do CPR as needed, oxygen, monitor, IV, burns, dry sterile dressing. Do remember on burns it's dry sterile dressing, because if you see that on a registry, that's one of the things they like to slide through there is it dry or not. Kane, what are you doing? I know. Why don't you- why don't you not? Yeah. Come on now, give me a break. You too? No. Okay. Yeah. So what I'm going to have to do if I ever come back, and I may not ever come back, is have you put your phones up on the corner where I can see them. Well, I know you're not using them. Okay, radiation burns. I will say that you're probably not going to get much radiation burns on National Registry. It's not covered much in the national standards. Do be familiar with your alpha, beta, and gamma rays. Which one's worse? The gamma rays. Where do you get those usually? The X-ray machines. Yeah.
That's what they're called.
Yeah. It's repair.
That's right. Acute radiation syndrome. Oh, man. I don't want to survive a radiation attack. Hematological, central nervous system issues, stomach issues. I hate that. Unresponsive patients who vomit within 10 minutes of exposure usually will not survive. So vomiting seems to be a tip-off there. If you're vomiting after radiological exposure, it's not good for you. The burns, you may not recognize the burns. They may look like a thermal burn or a chemical burn, but they may also be delayed. So you can have a patient with a radiological burn that is delayed, and you may not see it. Assessment, make sure the scene is safe. This particular picture is showing you what shields these different things. It's like gamma rays are going to go through this and get you. The alpha ray clothing will protect you from an alpha ray. And the beta rays, this ambulance, some kind of metal will protect you from that. No. Nope, nope, nope. Make sure you wear the right protective gear. Management. If you can possibly decontaminate a radiological burn patient before you transport them, I'm not sure how you do that. Does anybody know? Did you read that in the book? Take their clothes off, wash them down. Irrigate any open wounds. Make sure you tell the emergency department what's going on, what type of burn you have, what the exposure was. And you want to limit your exposure to it. Now, if your patient has a chemical on them, can you then get a chemical burn by touching them and they've got chemical on them? Sure. Are you going to get a radiation burn by touching somebody who's a radiation patient? No, it's not going to be transferred like that. Good job.
It says most contaminants be removed by de-roping the patient.
Okay, take their clothes off and it takes all their radiation stuff away. And you can't get it just by exposure, so I mean touching them. Fluid resuscitation with pediatric patients. They may require more. Think about it. What's the, I know y'all talked about this recently. How much fluid do we give to an adult patient in a resuscitation setting? 20 milliliters per kilogram. How about for a 10-year-old? 20. How about for a 1-year-old?
That's it.
That's all, that's, yeah.
Yeah, y'all were talking about that the other day.
Depends on birthday.
The
Day
birthday.
of event.
Traditionally, it's always been anybody over 30 days is going to be 20 milliliters per kilo. And this is one of the reasons, even though they're small people, you're giving them a lot of fluid. They're going to require more fluid than an adult does. Also with kids, you may even consider something with a little bit of dextrose in it because they go through their sugar so much faster than adults do. They burn it off. They don't have a lot of glycogen stores. And I'm recording this? Oh, that's a mistake. Who else will fit that profile? Your elderly patients, certainly. And that may also include your homeless population. They're very thin. They don't eat well. All of these patients may require some fluids that have some dextrose in it. Your geriatric patients, remember back in EMT we talked about how quickly our body systems deteriorate? What's the rate there? How quickly do our body systems deteriorate? Not 12.
I said one.
Oh, I'm sorry, you said 12. Yeah, 1% a year after about age 30. So if you've got some guy that's 80 years old, okay?
He's in the negative.
Well, he's not yet. 1% per year. So his respiratory, his lungs, you're already starting at 50%. It doesn't take much of a compromise to really have a very negative impact on them. So you got to recognize that's a problem. And they're often much thinner too. Long-term consequences, average of 1 day of inpatient treatment for every 1% of body surface. So that's inpatient in the hospital. That doesn't include everything that comes up after that. We talked about the problems that they're going to have. For us, it can be very, very disturbing for us to treat a horrific burn. I mean, it's very disturbing. Summary, I don't have much summary here. Now, when I'm finished with this, we have an activity that we're going to do, and you're going to get points for it. So I suggest that we don't slam our books around and run out the door. You can take a break and come back if you want, or we can get right into it. Doesn't matter. Okay, just recognize that mainly we're going to have to get some fluids going very early in the process with our burn patients. They can have a lot of issues going on. What was that? Remember that the capillaries leak a lot once you have particularly a thermal burn, but also chemical burns, and that's one of the reasons that we have to have fluid resuscitation. Airway management, fluid, pain management. Pain management is not part of ABCs, but those other things are. So with burns, severe burns, our ABCs are going to be at the forefront of issues. You may have to intubate. Patients with 20% body surface area burns are going to need or require fluid resuscitation. The consensus formula is the new name for the Parkland formula. Be familiar with it. You're going to need to know it. And you don't have to have a calculator to figure those out. I mean, even I can do it on paper. Don't forget pain management with your patients. You would want it. Let's see. Most radiation burns are caused by gamma radiations or X-rays. Y'all can probably remember that. Pediatric patients require more fluid. They can be more challenging. Same thing with elderly patients. Couldn't find a good burn picture because they're all awful. Y'all want to run to the bathroom real quick? Take a quick break?